Yes, case number 2, and more important, I just want to say, I know that latest data with Lars showed a little disturbing actually in United States, that which patient getting the tower, particularly getting to the less than age of 65. I can tell you for sure at Mount Sinai, and this is for 100% fact because we are present on every case. No patient less than 65 is getting the tower unless surgeons say we cannot do the surgery. Absolutely, because I know within city things had happened. I lost few patients to other centers. There actually one case was 52-year-old bicuspid aortic valve got the tower at some other center, but that case will not get the tower at Sinai. So having said that, let's go to our case number 2, another valve degeneration, which you do less than 65, probably will see more patients of that kind. If we, this is it's a valve-in-valve tower, 26 millimeters. So today, these are the 2 cases of, we are showing sapien, then we show 2 cases of the evolute for valve-in-valve. That is, this patient actually had a prior degenerated aortic homograft. So with that note, this is a patient 74-year-old, has recent symptoms and risk factors shown there. Patient has a AVR for bicuspid aortic stenosis at age basically 18 years ago on 10/2005, followed by re-op homograft root replacement in 2005 also due to endocarditis. Patient has been on anticoagulation, and of course, just wanted to actually, then I will, once I make the presentation, I'll show my team member, which in this presentation I just skipped. We actually, can we go back to the camera once again? I think we need to, it's the right thing to do to introduce our team. Yeah, basically go back with Dr. Sahil Khera. He is the structural director of Sinai. Rest we are frequent visitor, all 3 of us. And then we have 2 fellows here, Manish and Anup. And they already have publication. The one publication of which I showed today was led by both Sahil and Anup of treatment of stroke post-TAVI. So coming back to the points, go to the slides
anesthesia
again.
is Minakam Meedan.
Oh,
He's
Dr.
the director.
Minakam.
He's the director of cardiac anesthesia here in Mount Sinai.
Beautiful. And of course, trying to keep those.
Exactly behind the II.
Yeah, that's the only thing our anesthetist friend cannot be seen.
So we can see you.
Yep, and and same also our echo, Dr. Larakas back on the machine. Okay, let's go back quickly. Basically this patient has aortic bioprosthesis and moderate gradient, and ejection fraction is quite good. Both valvular regurgitation as well as stenosis, and will show active. This is the TE which was done. Abnormal aortic prosthesis due to stenosis and regurgitation, and quite a bit of regurgitation. Coronaries were normal, but more important, look at the porcelain aorta. That is the key. Porcelain aorta, in this particular case, one of the big factor of decision making. Although 74-year-old patient already have 2 surgeries, it's a reasonable to do a tower in this particular case. But clearly, with the porcelain aorta, will get the transcatheter treatment. So with that note, Gilbert, on this CTA.
Let's maybe have Stam and Malcolm look show us the echo first. Shall we do that?
Okay.
Yeah.
Show the active echo now. This is the active echo now.
Yes. Stam, go ahead.
Yes, good morning again with Dr. Anastasios here. As you can see, 4-chamber view, normal LV function. This is transthoracic image with a second generation Philips Probe X51C that shows 3D ejection fraction of 55%. This is X-plane of the aortic valve, as you can appreciate, degenerated bioprosthesis with a flare, no coronary cusp of the prosthesis. This is with color, as you can appreciate, on top of the degeneration and some stenosis. You see also significant aortic regurgitation, valvular aortic regurgitation. This is gastric views of the ejection fraction. You can appreciate normal ejection fraction, non-pericardial effusion. And this is again deep gastric view of the aortic prosthesis, thickened leaflets, degenerated with significant severe aortic valvular regurgitation, pressure half time 234 milliseconds, peak gradient 15, peak gradient 37, mean gradient 15. This is the pulse wave through the aortic valve area 1.7. So mild aortic stenosis with severe aortic regurgitation. You can appreciate here the 3D image of the aortic valve with the flare, no coronary cusp leaflet, significant aortic regurgitation in multiple views. And this is the area, 5.3 centimeters square of the aortic annulus by 3D echo circumference. 8.41 centimeters. Thank you very much for your attention.
Okay, so let's go back to our slide presentation now. We show the CT images in this particular case.
Yeah, it's very important, I think, to look at it on 3DT because it's a homograph, right? It's not like a surgical standard valve that you can easily get the diameter. So you can see that here, to our best approximation, is pretty similar to echo. The valve area, the anal area is on 566. LVOT is smaller, 515. Mean diameter 26.8. You can see very calcified annulus where the homograph was sewn in. Next slide. And you can see that here we're just doing a 1 millimeter slice. This is require really much a detailed planning because you don't want to rupture the homograph. So you can see that here, this is 26 millimeter circle. It fits very nicely. Next slide. And you can see that here all the way up to the aortic root. Next slide. You can see calcified homograph. You can see that the STJ base is calcified sort of on floral. Big sinuses. This is consistent with the homograph. Next slide. And you can see the root is very generous in terms of coronary obstruction risk, so we're not worried about that in this case. Next slide.
Although left coronary height is a little questionable,
Right.
10 millimeters is your cutoff, but very
Sinus is big,
Sinus is
STJ
very
is
big.
big. Yeah.
okay.
And not a horizontal aorta, if you're typical for people with previous surgeries.
No.
You can
Okay.
see that here.
The portional aorta is a portional finding related to the homograph.
Correct, exactly. You can see that beyond the homograph, you can see where the suture line is. It's not calcified. It's just the homograph itself calcified. This very typical natural evolution of these. Yeah.
Anu, can you show the fluoro also? And then you did a sentinel by your
Yeah.
criteria. This case.
Let's show the
required?
fluoro, please.
Yeah, fluoro.
Yeah. So I think we discussed the criteria
No,
again.
But look at the
Prosthetic valve.
porcelain aorta,
Yeah,
truly
porcelain.
porcelain aorta.
You can see.
Well, it's not really a porcelain aorta, it's a porcelain valve. The
Valve,
aorta's
the
more
root,
the
about
root.
these-
Yeah,
these
but yeah,
homographs
exactly.
calcify.
Porcelain
Homograph.
Homographed. Yeah, that's right. You're right.
Let's be very
Porcelain homographed.
So
Absolutely.
Gilbert, talk to me about how you plan your landing. Do you plan for the native annulus or the homograph annulus? There's two annuluses in there now. How do you decide where you're going to land your valve?
Yeah, we're gonna look at the pigtail and see where it looks like on the. You can see the here where the base of the pigtail is. So that's kind of what we do with a Sapien 3 implant. That's kind of where we would target. We would want for a little bit more aortic implant, if we can, like 90-10. That's what we're gonna look at. We're gonna use the pigtail to help us because of the AI. It's gonna be harder to landmark, but I think that we're gonna use the pigtail to help us.
No, his question.
And you can see the calcium.
Right now, your picture is in the homograph.
Yeah, I know in the homograph, but you can see also the calcium at the base of the homograph as well. So
Or the
Yeah.
other
To me, it looks like it's not a leaflet which is calcified, it's a homograph.
correct, that's right.
The whole homograph's all calcified.
Is there risk for annulus rupture,
Yeah.
homograph fracture here?
Yeah, and again, this is very thick. I mean, Joe will tell you, or anybody's ever operated on these are god awful to operate on, and they stick to everything. But yeah, you can rupture this. The key is just kind of expand it out slowly. But again, I would plan to land a little deeper than the homograph annulus because there's a real annulus below that.
Yeah,
Right.
yeah.
Okay.
But these valve, we've done one before,
Yeah.
and these don't expand as much as you think they would be in terms of Sapien 3. It's very much constrained by the homograph itself, actually. But you're right. We'll aim. Yeah.
Is a homograph failure more prone to be a stenosis or a regurgitation, or does it matter, or we don't know? They all leak, so it's very typical to be a regurgitation.
But both these and the porcine grafts, they generally fail with regurgitation, not stenosis.
Right.
It's the wall that calcifies. Lord believes.
Interesting.
So Michael, any preference for self-expandable versus balloon expandable in a case like that?
No, I mean, you can use either one. To me, again, it depends on how big a valve you're going to get and how old or young the patient is. So if you can put in a 29 or even a 26 in an older patient, balloon expandable, you're probably fine. But if you get a younger patient, or a bigger patient, then you want better hemodynamics, and you're always going to get that from the self-expanding valve.
So what about regarding the risk of rupture? Balloon or self-expanding?
Well, again, I think as long as you size your valve right, you're going to be okay, but you will have less risk of rupture unless you have to post balloon. If you have to post balloon your self-expanding valve, your risk of rupture now returns just because of the post balloon.
So, but Mike is saying that you size to the homograph, but you implant at the native annulus.
Yep, that they did at the native annulus level. Now, Anu, comment on this sentinel in this case. Yeah, so use a sentinel in this patient, right? This will fall into that category, and then we'll complete our presentation.
Yeah.
Anu?
We have placed a sentinel here.
So this is by criteria, our criteria at Sinai, this patient will get sentinel, and I'm sure most of people will agree because of this calcium and so.
Eberhard, you had a comment?
Yeah, I humbly disagree with what Michael said. I mean, if you have a homographs with TAVR is really a problem, and it's not only rupture; it's anchoring and much more, involved in that. If I have a choice, I would not do a balloon expandable here for the reasons that you yourself just mentioned. Why risking it? Yes, you can do it, but why risking it? If you take a self-expand, you have more tolerance in terms of positioning and much less danger of rupturing.
T up, please.
Tell Gilbert, you want to answer that question, Eberhard, that he's saying self-expanding versus balloon expandable?
I would.
Yeah.
But if you are using the 26,
Too deep,
they are using
too
the
deep, too
20,
deep.
you're not oversizing
Not
at
hard,
all.
not hard.
That's
hard.
what exactly Matt says.
You're
Not
not oversized.
size to the
No deeper.
homograft and implant at the native annulus.
The 26 has an area of 560, so you're
Dr.
really
Herman has a
Yeah,
comment.
I was just going to add,
Okay,
you're right
180.
you're right sized for a 26 sapien, which should be okay. But I would implant a little bit lower than the sinuses. The homograft annulus is where it's
Off.
going to sit.
I like it.
Yeah.
And that's where you don't want to oversize.
Yeah.
So it's the
Right.
annulus
I
that
would
you
go
want to
with that.
position.
Huh?
So where you are
Good.
now looks very nice. It's the
Yeah,
homograft.
that's where we are
that
going to
you
do it
want
now.
to
Yeah.
Implant that.
Okay, we are ready to implant.
Okay,
So go
everyone listen.
180.
Everyone listen, Dr.
Yeah, I
Kinney.
think they did exactly what was described and discussed here, sized at the homograph diameter and positioned
Okay, going up.
a little lower so it
What do we-
captures the native valve annulus.
Did not
And
open well.
you can see it did exactly that.
But still the valve doesn't look like fully expanded.
Okay,
off.
off.
So you can stop the.
I think you have to post again.
Facing.
No, it looks
Did
okay.
not, would
Very
not
It
go.
looks
good.
okay.
But post with different balloon? Now,
Let's wait,
Gilbert,
let's
you want to answer that your choice in this case,
Yeah,
balloon
so-
expandable.
so-
yeah.
That's the calcium. If the over balloon is the one that's going to shove out.
That's exactly
I would
right,
be very
Mike.
Careful before I re-balloon this.
Well,
Correct,
let's go,
exactly
Dr.
right.
Let's go to measure the gradients and all that. And the
Let's look
PVR.
at the
Let's
echo
look at that.
first. I think that's a very important, and Stam can comment on that.
Considering the amount of regurg he had before, even
0.5
as
cc
minimal.
was-
Stam, can you tell us what you
have-
find?
Yes, there is some central
And the risk of
We
still have the wire across.
AI,
very high.
no much PVL, but I have to go deep gastric
Yep, go ahead.
for better evaluation.
Go ahead.
Yeah.
The valve could have been a little bit lower, no?
Hmm.
Yeah, so
It was,
Eberhard, everyone's asking about the deeper.
No plus.
So if you look at the LVOT, it's around 514. If the LVOT is smaller, I would probably gone a little bit lower. But the concern is the AI is the mechanism, and I want to maximize the sealing of this valve against the homograph, because the LVOT, as you saw in the other case, it's going to dilate and you lose the seal zone if you implant a little bit on the more
Can we get
ventricular side.
echo pictures
So-
better?
Yeah.
Yeah.
Dr. Bono, when someone starts with a 4+ AR,
We,
Change
and then we
the.
end up
we
with
can't
a-
see very well.
Can't see well.
Is that real, or is really, are we kind of
Because, yeah.
over-treating here or over, overexcited about the result?
No, I think the reduction in AR here is really significant, and maybe all you need to do.
Wait, we
because
don't do anything.
Let's get a gradient. I wouldn't post
the
this.
risk
No,
of
no.
going back in and trying
Okay,
to
gradient.
eradicate
P gradient 12,
the
mean gradient 5.
is too high. I just leave it
Minimal
alone.
PVL.
So the benefit
How
might
much?
be
Minimal.
when you
Okay,
go
good.
from 4+ to 1+.
I agree.
Go from 1+
Okay.
to 0.
We are going to do a hemodynamic also here, just to show.
So
The gradient is about
And then we'll do an
12.
aerogram at the end.
And then we'll do the aerogram in the end.
Have any
And the
chance.
point is very well
But
taken
exactly the same.
that although there is a dent on the top of the valve, but I think going further may create more trouble. And if the gradient is in single digits, I think it's reasonable to leave it.
Yeah, and also look at how the valve sits. It actually shifts it towards the left sinus because there's so much calcium on the non-side that it is non-compliant. So I agree with everybody that I will not post this unless there's a significant amount of PVL. And I think the hemodynamics is fine. And to your point that we like to implant balloon versus self-expand, I think it's whatever you're more experienced, because we do so few of these, right? First of all, we found that the balloon expandable, at least in this particular anatomy, is a little bit easier to track and also more coaxial. I think that, and I think that this is probably where we might consider one versus the other, and also the mechanism of failure as well. If you have a smaller LVOT, I think you can argue that it will be sealing better with the self-expanding. But yeah, I don't think you can go right or wrong with either valve as long as you size it appropriately. How does it look, Stan?
Yeah, looks good.
Let's
Looks good.
flush the channels. We're all looking now in the hemodynamics. Flush the
Yes.
channel 0, and we
Done.
can see where we
Yep.
are. I've already seen that the LVDP is markedly low, which is a great result.
It's great.
Okay.
Menachem pressure is on a little high side, right? Put all the pigtail. Pull the pigtail. I think it's maybe just a lot of PVCs.
Yeah, pull a little bit back. Yeah, a little bit back to stabilize
Yeah,
this.
good. Okay, just 5. But
No,
So I don't see there's a gradient here.
There's no gradient.
There's no gradient.
All right,
No
can we put a
invasive
T
gradient.
probe up? We do the aortogram now.
Yes.
Yep. Bring back the.
Diastolic pressure has stabilized about
Yep.
to about 80,
Yep.
and the LVDP is about
10.
20.
Yep.
That's a great hemodynamic result.
Yep.
Go a little bit more.
And,
thing.
Yeah, good.
180 over 20 and
Menachem, from
180
your
over-
point of view,
over
everything looks
80.
good.
Okay, good. Ready?
The blood pressure.
Okay.
Yeah.
All right, we're doing the aortogram.
Oh, what happened?
They fixed it.
Go.
Great.
Wow. Not even one RBC going down there.
So you can see actually it's not that aortic on the non-side, right? It shifts, and you can see the calcium below that portion of the homograph, Mike. I think so. You ended up. I think this is a
Quite
pretty
low.
acceptable result.
And guess what, George?
Excellent.
George and Roxana, that we
Yeah, looks
finished
like-
exactly at 10:30. We
I was
finished
just thinking
exactly
about that.
10:30. Time for the exhibit. Let people to go
We're
15
back
minutes
on
break.
time.
Yeah.
We're back on time, and let's
Yeah.
give congratulations for completing everything on time. Let's thank
Beautiful.
all the panelists and give everybody 15-minute break. Come back
Yeah.
to the room. I'm gonna kick off the next session with a talk on TAVR pharmacology and durability.
Beautiful.
Great.
Thank you. Thank you.